Hi guys, so I'm going to be talking about the shoulder today. Okay, so for the shoulder, there's 4 joints, okay, that make up the shoulder girdle, however you want to call it. And some of these joints go outside of the normal shoulder joint that you guys would normally think of. For example, the glenohumeral joint, that is the true shoulder joint, okay? That is what you would think of when you like move your arm up and down, okay? All the other 3 joints play a really significant factor for the glenohumeral joint to move, okay? So all these kind of make up that one kind of shoulder joint for all that basic movements to happen, okay? So the sternoclavicular joint, okay, the SC, okay, is located right in here if you're looking at my picture right there, okay? Okay, because the sternum's right here, okay? The clavicle, if you want to break it down, okay, sternum, and then clavicle, clavicular, okay? So where it's the sternum and clavicular attachment, okay? So clavicle, okay, sternum, which is right up in here, okay? Just to the side, okay? You got 2 of them right in here. I've usually palpated them like a little bit tender if you can kind of feel, okay? The next one's be the AC joint, okay, and the acromioclavicular joint. Okay, so that one is going to be, you follow your clavicle to the outside. It's not quite on that kind of flat outer tip, okay? It's just kind of inside of that, right up in like here, okay? That is my AC joint, okay? We talked about glenohumeral, okay, which is that ball and socket. Next one is the scapular-thoracic, okay? So this one isn't, this is as the less of a joint as you could probably get. So this is where your scapula, okay, which is your, not collarbone, your shoulder blade, interacts with your ribs, okay, your thoracic ribs, okay. So I wish I had a good model. So if my scapula is my hand and my ribs are kind of like here in the front, so this where the scapulothoracic plays a factor is how that scapula moves, rotates, kind of goes around the rib cage, okay, which is really important to what's really important because without that scapulothoracic movement, okay, and the use of and the movement of your AC and SC joints, okay, you have virtually almost no movement in your glenohumeral, okay, pretty much like down in here only, okay. For example, on your scapulothoracic, for each, with your scapulothoracic and your glenohumeral, for each degree of shoulder abduction, okay, that happens at your glenohumeral, let me get this right. No, for each degree of shoulder flexion that happens at the scapulothoracic, 2 degrees happen at your glenohumeral, okay? So if I abduct my glenohumeral 30 degrees, okay, my scapulothoracic has abducted 15, okay, for that to happen. So as I abduct my shoulder here, okay, abduct out to the side, okay, my scapula is also kind of abducting in kind of this external rotation that occurs, okay, and that's normal to happen, okay, because the to break down your glenohumeral, okay, your humerus, okay, which is your arm bone down here, and then your glenoid is part of your scapula, okay. It is that the glenoid is that socket, which is on your scapula, which I think I'll have a few slides here. I'm going to show you more of the kind of rough anatomy that happens. Now, in all these joints, okay, especially the SC and AC joints, movement does occur, okay? Even though at your SC and AC joints, okay, up in here, movement does occur, okay? It's not a lot of movement. It's usually a little bit of rotation that occurs, okay? Maybe a little bit of like that bending that occurs, but it's still very, very important for all the normal range of motion that we need here in the shoulder. All right, so for the SC joint, the sternoclavicular, okay, is the only connection between the upper extremity and the trunk. Okay, that is it. Okay, movements of your SC are elevation, depression. Okay, anterior, posterior, rotation, or combination of all these. Okay, all that happens at your SC. Okay, it goes up and down and all this. Okay, the AC, okay, is a pretty weak connection, and that is up in here. Multiple ligaments help keep that clavicle kind of down. Okay, so in those ligaments, okay, you have your sorry, we'll go up here. So your acromioclavicular ligament, okay, that's your big AC ligament, okay. Your coracoacromial ligament, okay, and then your coracoclavicular ligaments down in here. There's another one that's kind of back deeper in there, but don't worry about that right now. So usually when you have a sprain to your AC joint, usually like you would fall, hit your shoulder on the side, whatever happens. Usually it's a sprain to the AC ligament, okay, the acromioclavicular ligament, and occasionally a few of these other ones, okay. Some of the really bad AC joints, you actually see the clavicle kind of pop up, okay, and that's normal, and it hurts like hell, and there's really not a lot you can do for it. Very rarely will they actually do surgery for some of these. I've only seen, of all the AC sprains, I've only seen one out of, I don't know, probably 100 or so AC sprains, and that's because it was like this, okay, and not attached to the acromion anymore, which acromion is this kind of flat area down here. And then here is your glenohumeral joint, if you look right here. Okay, so the glenohumeral joint is really a really crappy ball and socket. Okay, you see this is the ball, okay, of the humerus, and this is the glenoid, this little socket here. Okay, where the hip joint, okay, is more of a true ball and socket joint, to where you have a big socket that fully encases that ball. Okay, where the shoulder, you have this very, very small socket, there's very large ball. The upside of this kind of really poor ball and socket joint is it allows for a greater movement to occur. Okay, because the hip, you don't have as much movement as your shoulder. Okay. Okay, if we didn't have all this movement, it would be very, very limited, almost like the hip. The downside of all this extra motion is there's more chance of injuries, okay, as a result. Okay. Okay, here's that ball and socket-ish joint. Okay, you see here's an x-ray. Okay, here is the glenoid. Okay, and here is the head of the humerus. Okay, that ball. Okay, so in this ball and socket we have what's called a labrum. So this labrum is this cartilage, okay, that kind of makes that socket bigger. Okay, but it's this fibrocartilage which adds some stability, adds a good amount of stability, but not the best stability. Okay, so there's always a lot of issues that happen when you get like labral tears. You can get some fragments sometimes in the labrum that just kind of limits and causes a lot of pain. Okay, the labrum does extend out and fully encases, for the most part, the humeral head. But it would come out to like here. I wish I had a better pointer on this, but it comes out and makes that socket much larger. Okay, now stability for the glenohumeral joint, there's active and passive mechanisms. The passive one is going to be the labrum and the capsular ligaments, okay, which is just part of the this capsule that encases the entire glenohumeral joint. And that's your passive mechanism. That's what you rely mainly on. Okay. Then the active mechanism is pretty much the muscles, which is your deltoid muscle, because you have your anterior, posterior, and middle parts of your deltoid. Okay. There's like the anterior ones in the front, usually overdeveloped in everyone. The middle one's usually decently developed, and the posterior one's usually not even touched. Okay. And then your rotator cuff muscles, which we'll talk about here in a little bit. Okay. Because there's 4 rotator cuff muscles that play a big part in the stability of the shoulder. But for the most part, everyone relies on the passive mechanisms for everything. And it's not the end of the world, that's just what it is. So if someone has a shoulder dislocation, which we get towards the end of the PowerPoint, I believe, the labrum and especially these capsular ligaments are stretched out. And as a result, you have to rely mainly on this active mechanism to provide stability. Which the downside of the active mechanism is you have to be consciously engaging these muscles for that stability. Okay, so if you're not consciously engaging them, you don't have that stability. Is that kind of really bad downside? And once you stretch out these ligaments, they're always like that. They can go in and kind of like tighten them up through like surgical means, but they don't always stay that way. Scapulothoracic. Okay, so it's not really that true joint as I mentioned earlier. is that articulation of the scapula on the thoracic rib cage. Okay, so there's your scapular here. You see the ribs underneath. So you have this kind of like downward rotation. The scapula also externally and internally rotates. It tilts anteriorly and posteriorly, depending. So it does a lot of different things. And it all depends on the movement of the humerus and the movement that it needs to be in. Having a good scapular thoracic rhythm is really, really important. And a lot of athletes suffer from a lot of this. And it usually results in some kind of injury, chronic injury, altered throwing mechanics, altered mechanics, period, because there's a lot of compensational issues that result from all this. And the scapular thoracic rhythm is just how your scapula is affected and moves appropriately to whatever motion your arm's doing. Okay, but a lot of muscles play a factor. So if one of these muscles is affected, let's say it just even has a knot in it, that could affect the entire rhythm of your shoulder. Okay, for example, if you have let's say a weak lower trap. Okay, so your lower trap is really important to keep your scapula depressed. Okay, let's say if it's really weak, your scapula is going to migrate upward, okay, anteriorly, okay, and even tilt anteriorly to go and then roll your shoulders over, okay, as a result of a weak lower trap, okay, which affects all the other motions of your shoulder and can give you more issues like rotator cuff impingement or bicipital impingement, altered throwing mechanics, a number of things, okay. That is a more advanced topic of the scapulothoracic rhythm, but that is more of that kind of like the gist of it for you. All right, rotator cuff muscles, okay? As I mentioned before, there's 4 muscles that make up your rotator cuff. Okay, you have your supraspinatus, infraspinatus, teres minor, and subscapularis muscles. Okay, and we'll talk about where those are located. Okay, so this is the best picture that shows them. Let me go with this. Go through a little bit. All right, so this is a posterior view of your shoulder. Okay, so this is just showing your some of these muscles I talked about. Okay, so this one right here, this is your supraspinatus muscle. Okay, this big one right here is your infraspinatus muscle. Your teres minor sits right in here, and then the deeper one is your subscapularis, which is kind of on the anterior side of your scapula. Okay, but still on your back, okay, on your back side, okay, so still anterior side of the scapula and more of a closer interaction with the ribs. Okay, there's another picture here. Okay, we have your infraspinatus here. Okay, here's your teres minor. Okay, and your supraspinatus, which sits up here. Let me go back to this picture. Okay, so here is sorry, this picture is kind of brutal. Your subscapularis, okay, which sits on the anterior side of your scapula. Okay, you really can't palpate it because it's so deep in there, and that really does a lot of the internal rotation of your shoulder, okay, of your humerus. The infraspinatus, okay, and teres minor, okay, sit really posterior, and those ones do a lot of the external rotation of your humerus. Now the subscapularis, which sits on top, its primary goal is stability of the humeral head into the socket. So what it does is when it contracts, it pulls in that humeral head into that socket for greater stability. I mean, all of the rotator cuff muscles are really responsible for stability, but the supraspinatus is really kind of like the king of all of that, and it pulls it in. It also only does about 30 degrees of shoulder abduction. So here about to like, that's a little more than 30, okay? Here to about right there, okay? And then after that 30 degrees, your deltoid takes over for the rest of your shoulder abduction. So to kind of break down some of these like supra and infra and subscap and all those. So if we look at your shoulder blade, okay, your scapula, okay, this is what's called the spine of the scapula. So you can palpate on yourself, okay? You find this really kind of hard ridge that comes down like right in here, okay? That is the spine of the scapula. Okay. Just above that is going to be your supraspinatus. Most people, it's underneath your upper trap. Okay. Okay. So if you break it down, super means above. Okay. Above the spine. Okay. That's where your supraspinatus is. Your infraspinatus. Okay. Infra below. Okay. Below the spine of the scapula sits there. I don't have a clever way of teres minor. Okay. Because there's also teres major. Okay. And then the subscapularis. Okay. Sub means underneath. Okay. Under the scapula. Okay. Which is deep in there. Here's another bony thing. Okay, so here is the subscapular fossa, where the subscapularis is. Okay, and it comes and attaches over here to the lesser trochanter. Sorry, lesser tubercle. Okay, so that's where the subscapularis is. Okay, up here. Okay, here's a good picture of your AC joint. Okay, your acromioclavicular joint. Okay, your scapula your clavicle right here. Okay. Your acromion process, that is kind of like the tip, this flat area right here on the shoulder. Excuse me. Your coracoid process, okay, so this is a little process that kind of sticks out. It's like a little hook that sticks out in the front, okay? And that is right up in here, okay? Below my scapula a little bit, okay? Sticks out a little bit, part of your bicep tendon attaches here. The other part attaches up here on the capsule. Sometimes it's a little tender. Okay, especially like some tendinitis or just like overuse or whatever it is. Here is the head of the humerus. Okay, you see how big it is compared to the glenoid socket. Okay. So I said your subscapularis attaches here to the lesser tubercle. The other three, the supraspinatus, the infraspinatus, and the teres minor, all attach to your greater tubercle. Okay, along the backside of here. In here we have your bicipital groove or intertubular groove. I like to call it the bicipital groove, okay, which is right between your greater and lesser tubercles, okay. So this is where the long head of your biceps tendon kind of runs, deep in there. And we'll get to that here in a minute on the importance of that. Don't worry about palpation, they took that out. Here's some other anatomy. Okay, so here's your glenoid cavity, okay. So this is like the socket, the ball and socket. Okay, and then your labrum, okay, kind of makes it a little bit bigger. Okay, you can see the little glenoid labrum right here. Okay, it makes that socket a little bit bigger. And then the rest of this is your capsule, and with all the ligaments that are encased within it. Okay, these two muscles here are your bicipital tendons. Okay, this one is your long head up here, and this is your short head. It's longer, go figure. Okay, and that's where it goes through. You also have this. Excuse me, transverse humeral ligament that is about right in here. It's a little ligament. It's about yay long, and it goes just over this long head. It helps us kind of keep it intact in place because remember it's in this bicipital groove, which I mentioned previously. So it's very, very common for that ligament to tear. Usually it's not painful. Okay, it's very asymptomatic, and results in whenever you move your shoulder in whatever motion, usually abduction, whatever it is. This biceps long head tendon pops out of this groove. And it can cause some irritation. You might even feel or hear that pop a little bit. And just every time you do it, it's just a pop, pop. Most of the time it's not painful unless you do a lot of overuse injuries or overuse movements, and it can cause just some inflammation. So it's very, very common in there. Okay, some other muscles you can see. Okay, so the pec major has been removed here. Okay, you see this is the pec major right here. It's been removed. Here's the tendon of your pec major. Okay, so here is the biceps brachii. Okay, or your biceps. Okay, here's the long head up in here as we talked about. Here is the short head. Then here, here's your coracobrachialis, which is another kind of like bicep-ish muscle. Here is your pec minor. Up in here, there's a lot of stability. You can get really tight a lot of times. Here deep in there is your subscapularis muscle. Okay. Let's see what other good ones in here. Really, really important. Here is your brachialis. Okay, you can see deep in here, just under the bicep. Okay. Given we talked about elbow previously. So that is your brachialis muscle. What other really good ones are important for you guys to know? I'm going to stick with that for the movement. Another one here is your serratus anterior. Okay, so this is a very kind of broad muscle, very, very important for that scapular thoracic rhythm, as well as just shoulder motion in general. So as you see, it attaches, okay, down here to the 3rd through 8th ribs, okay, and wraps all the way around to the medial side of your scapula. Okay, so you see where it attaches here. Okay, this is all your serratus anterior, all these, and it attaches on right here. Okay, so do you have another good? Okay, so it attaches right here in the medial border of the scapula, wraps all the way around to the front side of the ribs. Okay, so the serratus anterior is really important for this kind of forward shoulder motion to occur. So if I was here, okay, going forward, okay, that's all serratus anterior. Okay, just that forward motion. They like to call it the punching muscle because in boxers you see these ripples down the side of their body. Okay, and that's just a very developed serratus anterior. It's also a muscle that's really, really important to help keep your scapulas, okay, flat against your back. If you have what's called a wing scapula or wing scapulae, it's just a poor control of your scapula because of like either poor development of your muscles, injury, usually some kind of neurologic. And so usually the number one thing they'll do is strengthen and try and activate their serratus anterior because they maybe don't even have any of that motion. But the people that have this wing scapulae, their scapulas like just kind of stick out on their back. Okay, especially given the push-up position, excuse me, and that scapulas will just kind of like stick out instead of being flat against your back. Okay, or just more kind of around your ribs. Okay, so here is the tricep, another picture here. Okay, the elongated tricep attaches to the scapula. The other two lateral head and the other one underneath it attached underneath. Let's see, here's a good picture of your supraspinatus. It attaches up in here. Teres minor. Teres major actually does internal rotation of your scapula. Okay, we don't talk about it too much. The teres minor does external rotation. There's no difference between the two. Your latissimus dorsi or your lats, okay, that is where this attaches kind of up in here. And most of that picture you can't even see in this anyway. Don't worry about palpations. Subacromial impingement. Okay, subacromial impingement, excuse me. So this is often called a shoulder impingement. So this is caused by a number of different factors. So what it is this is impingement of this subacromial space. So if I go back a little bit, let's see what's a better picture. I think I'll use this one. So this little hole that comes out in here, okay, this is your subacromial space. Let's see if you get that picture. So this little hole right here, okay. Excuse me. So when this area gets broken down or collapsed for whatever reason, you can cause a lot of impingement of different structures. Mainly the biceps longhand tendon, which comes out a little bit higher than this, okay, up in here. Then you have a bursa, which right here, you have your subacromial bursa, okay, and then you have the supraspinatus tendon, okay, as you see in here. So this subacromial space deep in here where this subacromial bursa and the supraspinatus tendon go through, if that gets collapsed through a number of different reasons, you can have a significant amount of pain that happens through here in the shoulder. It can cause like fraying of the supraspinatus, really bad bicipital tendonitis, bursitis, which is inflammation of that bursa, and a number of different issues. Okay, so the biggest thing that happens here is, or the biggest factor that we can control is posture. Okay, so before I get to this, so if you're standing up nice and straight, okay, and your shoulders kind of back and depressed, how a normal posture should be, that subacromial space is pretty open for the most part. But once you start kind of rotating your shoulders forward, so going from like here to more like a rolled forward position, which a lot of people have, okay, that subacromial space just gets slowly and slowly kind of reduced, which can cause a lot of real issues down the road, especially long-term wise. So posture is the biggest thing. Proper development of all the muscles that play a factor on your scapula are another one. Another one is the hooked acromion. Okay, so that acromion is that flat area here. Okay, so there's 3 different areas to where it can have this like hook. Okay, so there's the flat, and then the curved, and then the more the hooked. So this more of a hookage, okay, can cause issue and a further reduction of that subacromial space, which cause more inflammation ultimately. So a lot of time with people that have the shoulder pain, they'll look at it. If it is like a hooked acromion, they'll probably do physical therapy first, and then the surgical options go and they'll actually shave this down a little bit. So I've actually not seen that too often, but that is not the population I usually deal with. I deal with more of the athletic population. This is more maybe the geriatric or more active adults, the older population, that you may see this more commonly in. You see it occasionally, like I saw like 1 or 2 in high school and college athletics, but he wasn't a surgical option at this point. Okay, but that can play a factor. Shoulder testing, I took these out. Skip some of these. Brachial plexus injuries. All right. So especially we're talking about the stinger or burner. Okay, really, really common. So this is the mechanism of injury is going to be either a traction, compression, or contusion force. Okay, so this stinger, which we like to call it, is usually a very, very common in contact sports, mainly football, to where after a hit, like your arm's numb. You can't move it. It can be tingly. And what it is it's an injury to the brachial plexus, which the brachial plexus is this kind of bundle of nerves that come off of your neck. Okay, and they go down and innervate pretty much the entire arm. Okay, so the 3 things I mentioned earlier, okay, A is a traction, okay, which is really common here. So let's say they're going to make a tackle, okay, they're going to go in and take the hit with their shoulder, okay, so the shoulder's going to kind of go back of the hit, and the head's going to go away, and it's going to result in this kind of traction, which is a stretching of that nerves, okay, resulting in injury. Excuse me. The next one is a compression, okay, as you see here, and that's more whatever happened with the hit. My shoulder comes up and my head goes towards it, okay, and that's just kind of more like a crushing injury on those nerves, resulting in injury. And the last one, B, is going to be that compression or that contusion, which is just like that forced hit, excuse me, to those nerves. Okay, there's not one that's better than the other. It all just depends on the individual and the extent of the damage. Okay, it's the best one. Okay, ice it to try and calm down that hyperactive nerves. Rest it. You can try and prevent it depending on if it's sport specific or not. Maybe a lot of time you'll see football players have the horse collar, okay, on their pads, which is just kind of like thick padded foam that actually attaches to their football pads. It limits their head motion. Another we'll see is the, what's it called? It's this kind of, I think it's a cowboy collar. It's this flat piece that kind of comes up, almost like the back of a car seat in your car. It attaches their shoulder pads, and it prevents your head from going back. Okay. Those are some things you can do to help try and prevent it, as well as the general strengthening and just like rehab of the shoulder in general. Rehab is going to be a lot of the cervical musculature. Kind of develop all those, okay? Any kind of functional exercise, okay? Like turning their head to try and like get more range of motion as I go into more of that. More kind of protection-ish things. Generally, the brachial plexus injuries or the stingers will kind of go away on their own. If you get repeated stingers, you can have a lot of neurologic issues down the road with just the, either pain or just the muscles coming off of that are innervated by those nerves. Next are going to be shoulder dislocations. Okay, as you see here is the acromion process. Okay, that kind of tip of the shoulder, and you can see that you don't have this rounding anymore of where the deltoid used to be, as you see in the shoulder, okay, as a result of that dislocation. Okay, so really, really important. First thing you want to do is you want to check distal pulse, okay, usually the radius, okay, to make sure that they still have that blood flow. Okay, if they don't have blood flow, that is a limb-threatening emergency. Very, very important. Okay. Next thing you want to do is put them in a sling. Okay, sling them up. Do not try and reduce it or put it back in place. Okay, it's very common to cause more damage for you to put it back in. Always try and send it. Have a physician do it, okay, or someone trained and allowed to do it. I say trained and allowed because a lot of times athletic trainers can be allowed to. Okay, but we have to have doctor. Not really supervision, but doctor's orders, okay, that we're allowed to do like a shoulder reduction. And there's a lot of steps that included with that, like they have to have all these different check marks for us to be able to do it. Okay. Also some nurse practitioners, PAs, physician assistants can do it. Maybe some PTs, I'm not really sure on their scope with this, but usually just always leave it for a physician. Just put them in a sling, which will take a significant amount of pain away. And they're always going to present in this position, okay? They're going to come carrying that arm, okay? That kind of carrying position, if you will, okay? 100% of the time, okay? That's what's going to be in because they're very stable and more comfortable for them, okay? Here's an x-ray picture, as you see. Here is the humeral head, okay? And here's the glenoid where that humeral head should be sitting. Okay, so that's what it would look like. And this is a real one, real picture I got right from the horse's mouth, which is my brother, which has a chronic shoulder dislocation issue. Next one is going to be clavicle fractures. Okay, very, very common, especially in adolescence, around like 8th grade, freshman year in high school, sophomore year is very, very common for clavicle fractures. Okay. Now, the mechanism is Fuchs. Okay, if you remember from previous chapters, that's fall on outstretched hand. Okay, or some kind of trauma. Okay, usually clavicle fractures don't require that much force to result in that fracture of that clavicle. I heard somewhere this could be a myth. It only takes about 7 pounds of pressure, given that it depends on the stage of development and age and bony factors and girth and all these different factors, but it doesn't take a lot, long story short. Treatment, put them in a sling, okay, immediately. That takes a lot of the pressure off. You can put some ice pads over it to try and like for some numbness. Bleeding if that part of the clavicle, that sharp part pointed through, poke through the skin. And always refer to them to like the ER, okay, or a really good urgent care. Okay, and they'll see whatever is appropriate for that. A lot of the time, they're not even going to touch it. Okay, they're going to do what's called let it heal on its own. And it's called, I believe it's a Z fracture. So instead of the clavicle being nice and aligned, after it breaks, it's going to come kind of back and kind of overlap one another. And it's going to heal like that. And there's going to be no issues at all. After it's healed like that, it's just as strong, if not stronger. It looks a little weird, especially because now that shoulder is actually brought inward. Okay, so the shoulder will be in a little bit. Nothing that you're actually going to see. Okay, and it's going to heal like that. And only one time where I saw them actually do surgery it was up like this. Okay, and it wasn't going back down. And that is it for the shoulder that I want to cover.